All right, we are live. Hello, everybody. This is the next installment of the Academic Life and Emergency Medicine Book Club. This month we're talking about how we die, and we got together a great group of ladies who all have various interests in this book. So I'm just going to have everyone introduce themselves, starting with Anne, then Bonnie, Clarissa, and then Jordana.
Okay. Hi guys, my name's Anne Smith. I'm an emergency physician from South Africa, currently working in George, which is a little bit outside of Cape Town.
Hi, I'm Bonnie Arquilla. I'm a professor of emergency medicine and the director of disaster preparedness at SUNY Downstate. I'm also board certified in palliative care.
Hi everyone, I'm Clarissa Rios. I am a, triple boarded doc out of SUNY Downstate Medical Center. I boarded in emergency medicine, internal medicine, and palliative care, and practice palliative care consults in Downstate.
Hi, I'm Jordana Heber. I'm a medical education fellow and emergency physician and practicing in New York.
Okay, great. So this book, How We Die, I chose because very recently Dr. Sherwin Nuland, the author of the book, had passed away. There were great write-ups about him in the New York Times and a lot of reference to the book that he had written, How We Die. And so I read up about the book. I discovered that it was a National Book Award winner back in 1993 when it came out. And with the aging of our population, with the recognized importance of palliative care in emergency medicine, I thought that this would be a great book to read and to discuss. The first question that we're going to talk about is here as follows. The author talks about hope regained, finding it, and needed to find it in other ways besides in medicine. Do you find that the book contributed to this concept and gave solutions? So essentially, did the book talk about finding hope and solutions? So I'm going to give this first to Clarissa. Go ahead.
So I felt, and we talked about this briefly, that the book, to me, it didn't. I think that if you look at the way that he tells his stories, his personal stories, when he talks about his grandma, and he talks about the stories, the anecdotes that stay with him, I feel like that as a reader and as a practitioner, I felt like that showed a legacy of the grandmother, and that in some way I think could be a form of people having hope for family continuing, hope for the future, hope that people always stay with you. But in terms of tools for a reader or a practitioner reader to instill hope in others, I really felt like it didn't do that. I don't know what you guys think.
I felt that he mentioned hope extremely late within the book and the various case studies that he talked about. But I do think the case studies were interesting and appropriate for how he kind of divided up how we die. I do think the book is dated, and I think it's really interesting to read it from a dated kind of point of view. Certainly, not only from the way he practiced medicine as a medical student, but how we were practicing medicine in 1993. And I thought that was incredibly interesting. I don't think I would hand that book to a family of a terminally ill patient. I think it's too difficult to a certain extent, and at the same time too simple. So it was like, make up your mind. Either be really medical and clinical, or be really anecdotal and easy. And so that was kind of my problem with at that point. I think it was page 233. This is to help you get hope, and I was like, I don't know about that. So I thought that was for me an issue.
I mean, maybe the point that all families go through these horrible things, including a practitioner. He says he reverted back to a place that all the knowledge, all the medical the medical stage that he had become went out the window. That's kind of interesting, and I think that in some ways it can make people hopeful that the dying process it's universal and that we all go through this kind of icky, horrible time, you know. But I don't think that, as you're asking the question, it met that criteria, or it did it for me anyway.
Jordana, what did you think?
So he opens the book really talking about demystifying this concept of dying with dignity that we in the public like to think, well, this is how you should die. Everyone should die with dignity, and it should be pleasant, it should be peaceful. And as a physician, realizing we see death often, maybe from even as a physician or from our own experiences, and realizing that this isn't really what happens, that death isn't always kind. And I think that's it's actually, I think in some ways, talking about that openly is a healing process and supportive to many people who've experienced that, either as a physician, having watched it, especially as a learning physician, realizing what you can offer to these families and working in the system that we are in right now. I think those early chapters did offer support in that way, and maybe to families who experienced a death that didn't go the way they wanted. So maybe if we look at it that way, we can say there is some support earlier on in the book for any family member or physician. But I agree when he says that there's hope. It is brought up pretty late towards the book, and we have to be careful with who maybe we'd recommend this book to, and if this book would be a means of support for that family. I think just talking about these concepts and bringing education into how the dying process happens and the different ways how a death is approached is good education as physicians, that we should be offering this type of information to the public and for each other.
And do you want to put in any comments?
Yeah, so I mean, I kind of agree with what everyone said. I think it would be very difficult. You know, the book is quite frank at times and quite kind of scientific, and then interspersed with these anecdotes or histories of patients that he's seen. And I think his language, he writes very well, but at times I think his language is quite blunt. And I think perhaps for a family grieving or going through a difficult situation, that might not be the appropriate time. But certainly for someone who's maybe a little bit more removed, it's from a layperson's view, I think it's quite clear the way he writes. But I think, I kind of agree in the acute setting, of a family grieving, it might be a little bit too much, for them to handle. And I think I kind of agree with everyone, like his mention of hope kind of came a little bit too late, it was quite a lot of hard facts, and then really only at the end he was kind of talking about, the hope that you can find in it. So, yeah, I'm kind of mixed. I'm not sure if I would give it to a grieving family, but it's certainly, I think the information is pretty clear and it could be helpful at times.
Part of what prevents it from giving to any grieving family, I think, also is the level of writing that this is at. This is not for your average run-of-the-mill family. The language, the vocabulary, the really beautiful, complex sentences are tough. And they were tough for me to read until it was really, the stories flowed and they were very easy to get into. But even knowing the science behind some of the scientific explanations was a little bit harder to get into. And I can only imagine that you just can't give this book to anybody.
Yeah, absolutely.
I will say that I wonder if, much like we should approach advanced directives with people when they're healthy and happy, running around and building families, should we introduce these anecdotes or stories or pathophysiology about death and dying and aging earlier, so that the bluntness doesn't bite, Maybe not this book, but just in general. Should people know what happens to your hearts, even if you're a healthy person, as you become an octogenarian, It's just a thought.
So let's move on to the next.
I think very strongly that what that Clarissa and Anna said is really important, who to give it to, who not to give it to. But I think the conversation, especially when you're a healthy geriatric, start thinking about these things is it's hard to do, but we've got to start somewhere, and so I think that part of it's interesting. That interesting article that came out about if you start palliative care when you start diagnosis of lung cancer, this could almost be the same sort of thing. When after your first angiogram, maybe you should read about what's going on. So I from that point of view, to a person with a new diagnosis, perhaps it could be useful. Or if not this specific book, some other one. And after all, the book is called How We Die, so I guess it's, to a certain extent, it's not all that hopeful. I mean, we're going to die. So if you think about it, so I guess we shouldn't think about that.
All right, let's move on to the next question. The author consistently seemed to me, and this question does come from Bonnie, to be subtly negative about researchers and their general approach to medical problems. Did anyone else feel this way? So this question is specifically referencing the researchers, the medical, those who have done a lot of the breakthroughs. So I'm going to first turn this to Anne.
Yeah, I found this question really interesting. When I first read it, I was kind of like, I wasn't really sure where you were coming from. But then I kind of reread a couple of sections. And I sort of got the impression that a lot of the time what he was getting at was that, researchers or kind of people doing hardline just medical science were kind of less concerned with the patient's experience and more concerned with the kind of science behind what was happening to them. So although they were very interested in finding out, what is the pathophysiology behind Alzheimer's, they were less kind of concerned with, what is the family going to go through and how are they going to kind of experience. So I think... he also he's obviously got a number of years of experience in clinical medicine. And I kind of got the impression that a lot of the time he was relying more on his experience, particularly the way he uses kind of anecdotes and patient stories, rather than kind of just the, hardline, this is the evidence or this is the research that's been done in a certain topic. Which is quite an interesting way to write. I mean, it's his book, so he can, write whatever he likes. And I think it was quite a refreshing kind of viewpoint. I'm not sure I really think he was really negative about the researchers. I think it's just his focus lies in a different area of interest. I felt that he was kind of just more interested in the patient experience and the kind of family experience around what was happening to them.
Bonnie, what do you think? You wrote the question originally. Do you think it was really just that he's coming from another perspective?
I didn't experience it like that. At one point, at the very beginning, I was like, why is he ragging on these scientists so much? I mean, thank goodness they were doing it. When he started practicing medicine, there was one hypertensive medication. It's like, maybe I come from, because my father was his generation and was a scientist, maybe I was a little hypersensitive, so there's the personality part with it. But I also felt like it made it I got an impression of a big, guerrilla medical center is that they weren't cooperative. That it was the surgeons against the biochemists or something. I was like, this is not, for me, it was not. I didn't want to read that in this book at this time. And I was just like, all these subtle. He kind of got over it by about halfway through the book, but at the point I was like, oh, is it like? I don't know. So that's why I thought perhaps it's just me being wrong and hypersensitive, but I had some stuff with it when I was reading it, and so I was very curious to see what my colleagues felt about it.
Jordan, what did you think?
I would say his perspective was to bring light that we need to focus maybe more on the emotional sides of this dying process, what the patient's going through, what the family's going through, and maybe it's become too scientific. The part where I think he offered his perspective where it really became evident was when he talked about how we have to label a death, define what it was, what the cause was, and how for him it's really more of a holistic experience that for many of these deaths, especially in the elderly, this isn't just an acute event that happens, but over time it's a more involved process than that. And how we're labeling it maybe doesn't really correlate with what's actually happening for these patients and for the families. I think I actually was really impressed with the amount of research that was in the book and the amount of historical references. I felt that as a physician that made it really interesting for me to read, and I wish there was more literature that has this and more discussion around those topics about how we got to where we are and where we're going. I think that's always important.
I think, and before we started the Hangout, we did bring up the point that maybe this book is, and Bonnie, you mentioned this in the beginning also, should we look at this book rather than an instruction on palliative care, really more of a study of the history of medicine and a timepiece reflecting when it was published. But in terms of the researchers, for me, what I found to be a more positive side of it was the thought that patients typically used to think of doctors always having their best interests at heart and only their best interests. But there are different types of perspectives that different types of doctors have. So maybe this idea that just because a researcher approaches you with an experimental drug, that may not necessarily be the best thing for you. And maybe this book could encourage patients and their families to, rather than accept everything at blind faith, to ask some questions so that they, not necessarily to be argumentative, but so that they can learn and have a better understanding of what's the purpose behind what the doctors are proposing for them.
You know, I would say that that might be true if it weren't the age of Google and the internet. But I find that the patients are coming to us with the experimental, you know. And I heard that 2 people got cured in South Dakota last week, rather than the other way around with my experience within oncology and palliative care and the emergency department, stuff like that. I find that we are, and this is a definite change from 20 years of practicing medicine myself. It's looking different. So, I think there should be a book, The Google Phenomenon. I need an MRI because Google told me so. And he didn't have any of that when he was practicing medicine. It was like the doctors brought it up. So I to a certain extent, yes. And for our population, it's a very different population. Even if they're not sophisticated, they certainly all have smartphones.
And you're the one who's from South Africa. The rest of us practice in Brooklyn. Now I'm in California. But what's your patient population like in terms of their understanding of death?
So yeah, probably completely different to the guys that you're saying. I mean, our population that our hospital serves, or most of the hospitals I've worked in, are generally kind of the poorer end of the scale, so lower middle class, and even up to really indigent people. Very few will have, not very few, most will have some formal education. Most will not have a postgrad or like a university qualification at all. So really to explain, even hang on a second. Guy, please, can you not do that? I'm really sorry. Sorry. So to just try and explain, pathophysiology or what to expect when someone's dying, or, what's going to be happening over the next few days or weeks, is sometimes we really have to resort to kind of very simple language, I mean, like you said, Nikki, like the language in this book I would never be able to use with my patients. And also we've got a very strong kind of cultural aspect to how people regard death in our population group. So I mean, we've got such a diverse country that the way, for instance, people of my background deal with death or handle kind of grieving is totally different to someone from, say, a Xhosa or a Zulu background, where death is treated as very ritualized. It's a very different kind of situation. So you have to kind of take those things into account. And often, while counseling a family, you may not understand at all their reaction to what you're saying, or why they're not making certain decisions. But you kind of have to. We normally use advisors, kind of staff who are of that cultural background to kind of guide us, which way we need to kind of direct things. We do have the occasional patient coming to us with printed information from Google, but that's really the exception rather than the norm. Generally, we have to do a lot of kind of patient education, particularly surrounding kind of chronic, almost palliative diagnosis, something like cor pulmonale or end-stage cardiac failure, which we see really commonly, and just kind of what people can expect, because there's still this belief that the doctor will give you medicine and you'll get better. But that's not what happens in reality, and the kind of just explaining that this is a long-term, palliative, recurrent process that's going to happen. It takes a lot of our time, but so it's very, very different, I think, to the kind of first world environment you guys are practicing in.
All right, I'm going to move on to the third question, and we've already hit on this a bit. Would you suggest this book to medical students? And I'm going to turn this over to Clarissa right away.
Hey, my dogs are barking in the background, just apologies for that. So I think if you're looking at it from a historical, as a historical book, I think as we spoke before the hangout, absolutely, I think it's cool. There's some really graphic and heart-pounding anecdotes about, you know, doing really invasive and heroic, and I'll do that in quotes as a palliative care doctor, I have to, heroic measures to keep somebody alive, that in this day and age would be considered almost, oh my gosh, hold on 1 second. My dogs are here now. Would be considered almost illegal, right? So I think that that aspect of it is very interesting, very cool. I don't know if medical students in our day and age are trained. I'm sorry, I'm going on and on rambling. The medical student, the curriculum available to them isn't sufficient to get them ready to read a book like this. I think this is just way too above their pay grade. And sorry, I'm going on, but yeah.
Let me turn it over. Oh, go ahead. Go ahead.
No, it's fine. I'm good.
I was going to say, let me have Jordana make a few comments on that. As an education fellow, what would you think about that?
You know, it's interesting to hear your perspective and think about what level medical students are and how prepared they are for really clinical work or these clinical experiences they're going to have. And I think the more we are able to engage them in conversations about the physician experience early on, the better. So I would actually think this is a great book for students to read in medical school and in residency, and I'm an advocate for promoting more reading, more literature that's not textbook reading, and talking about the physician experience, thinking about early on what kind of physician you want to be and what kind of leader you want to be in the medical field. And I found this, because the book is so well written with so many historical references, then it even has quotes that are outside the medical spectrum relating to death from political leaders. It's just, the scope of this book is really phenomenal, and I think it would be a great book for people to read at all levels of medicine.
I think one of the things that we need to just be aware of is that we still, just like we were, and I don't know so much Anne, because I don't know where you're trained, but curative medicine is what's taught in medical school. And so I think if you have people that have some training or have an open mind, like I guess the four of us, I think it would be helpful. But it has to come with that big, it's going to be sort of a paradigm shift that has to occur in order for them to really grasp it. I have many students talk to me and say, why don't we do this now? We need to cure. And I think that, unfortunately, even though we're introducing palliative care earlier in medical education, we're not doing enough to kind of at least give a different perspective of what life is about, that we're not going to live forever, that it's okay that people die, and that you're not a failure if the patient dies, as long as you do what's best for them and take them into consideration and their views and ideas. But I see what you're saying, Jordana. It would be a great conversation starter, for sure.
Bonnie, what do you think? Would you give this to a medical student you were mentoring? Would you recommend this for them to read?
Probably not. I can think of a few exceptions. If I had a medical student who was particularly, I found to be judgmental, without a great deal of conversation of understanding, or if I felt like during the course of the 4 or 5 weeks they were with me, we really didn't see cases that brought us to this conversation, then perhaps I would use it as a surrogate kind of thing. I mean, one of my problems with what's happening with medical students is they don't spend long enough with any one patient to see a continuum of what's happening with death. Even in the emergency department with, an 8-hour shift rather than a 12-hour shift, or things like that. I mean, I can't believe I'm saying this, but I think they need to spend more time with more people. So probably, I don't know. I also find, and I probably will be shot for this, the millennial reader, I don't think would be very good at this book. It's because there's a lot of parts of the book that get pretty detailed and pretty specific, and why am I reading quotes from Shakespeare and Gandhi, and which we all found fascinating, but I don't find that with the millennials who read kind of like, everything is abridged and shortened and condensed. Which, as I say that, I come full circle. Maybe it's a really good book for them to read because it'll slow them down to see that death is not quick. There's no such thing as sudden death. It's been happening for a while for a lot of people. They may look like sudden death, but it's probably not. And he even said that with the first patient who had died of a sudden cardiac arrest. It's like that guy had been dying for a couple of years with his obesity and his diabetes and that kind of stuff. So back and forth. I think it's pretty specific to the student. I don't think it's something I would say the entire class needs to read, like some other books that your Hangout has done that I thought everybody never should graduate from med school without reading that book.
Yeah.
All right, I'm going to move this now to the last question. And one of the things that I like to do with the book club is to try to convince other people for why they should read. And I recognize that not everybody likes to read for the sake of reading, which is what I like to do. Mm-hmm. So we try to bring it back clinically for the average doctor who doesn't have a lot of time. So clinically speaking, this book brings up a lot of aspects of palliative care. So the question is, what are the challenges to providing good quality palliative care within the emergency department itself? So within that specific location. And I'll start with Bonnie again, and then go to Clarissa, both being now EM trained with palliative care training.
I guess I have to say it's not that hard. It is a mindset, it's an attitude of, I'm going to take this from a palliative care point of view rather than I'm going to do emergency medicine and add in palliative care. So it's not hard. It's really easy. And I think that if we start getting our brains wrapped around that, having this conversation, yeah, we're all astounded that we are the first ones to talk to a patient with end-stage something or other about what's your advance directive. What do you want to do? It's amazing to me they've seen 50 doctors in the last 2 years, but I'm the first one to ask them that question. Probably I'm not the first one, but it's the first time that they are answering it. I think a lot of doctors talk about it nonstop, but nobody really answers them. So I think that, from that continuum point of view, I think it's okay. I also think that the other really big, especially in practicing medicine in the Northeast of America, is the litigious environment we're in. It's like people are afraid to not do every test that it says you're supposed to do to practice standard of care before you send somebody home. And whereas no, I'm not doing this test. We're not finding out this. You're going to go home, and your family's going to take care of you, and the hospice nurse will see you in 2 days. So, did that answer your question? Probably not. Sorry. But I really think that hospice, palliative care has a bad name to a lot of patients. That means you're sending me out and you're going to leave me alone and let me die. And if we can change that mindset and change that conversation that everybody's getting palliative care from all ways and everybody deserves to get what they need. What they need is the question is, I think, interesting. So I'll turn it over to Clarissa at that point after my rambling. So.
Okay, so I agree with Bonnie. I think it's very easy. I think the biggest challenge that we face is that people think it's challenging. I think we do it every day. We take care of symptoms every day. And I think that we need to give ourselves a little bit more credit about what we do on a day-to-day basis in the emergency department. I think time is the excuse that a lot of people use. But putting in a central line in a very dehydrated 94-year-old person is very tempting as well. An unnecessary central line in a dehydrated 94-year-old demented person. And so I don't think that it's time is an issue. I think that in general, people are just so caught up in the curative hero. I went into emergency medicine to save lives, and I think that again, a paradigm shift has to occur where people are interested in what they really went into medicine for, which was to do what's right for the patient. And I think most people want to do that. They just feel like they need to kind of just peel back all the layers of, medical legal issues and that kind of hero mentality that they kind of learned. But I will say one thing. One of the things that I feel is really important is for us to stop the treatment momentum in the emergency department. So it's really hard as a palliative care practitioner to walk into a room after Dr. Joshi, had sweat dripping down her face, putting in a central line, and she didn't go to the bathroom for 8 hours because she was taking care of grandma, and putting all these tubes, and had me sign these consents saying all these things about life-saving and hydration, and then Dr. Rios walks in and says, there's really nothing we can do treatment-wise. Let's think about everything else. So if we can do that in the emergency room and at least give options and possible outcomes, we are already doing so much. And I think I'm going over, so I will stop here.
I just have to say one thing, and then I'll. It's ask and medical students and residents and everybody after they present. Well, what is this family's goals of care? What is this patient's goals? And we've all said to people, "Oh my God, if I'm ever that demented, contracted, and disgusting, promise me you don't treat me." But yet we go and we treat that same person that just they're strangers. So. Goals of care, goals of care, goals of care. What are your goals? What do you want? What does the family want? Generally, nobody wants to suffer. Nobody wants to be a vegetable. I mean, I haven't done a study, but I swear I know it's not true. And when I see, what happens to my grandmas and my stuff, it's like, don't let that happen to me. Promise me you won't intubate me. And if we just get that. Sorry.
Yeah. I think one of the things that, Bonnie, you just said, the most important thing is that this cannot be an afterthought. And then for you, Clarissa, I think that this treatment momentum idea is so important. You get the ball rolling, and hours later, you have tubes instead of patients. Just the other day, I had a really great encounter with a patient who had a pretty serious diagnosis, and he just came to the ER for pain very early on, but diagnosed with something very serious, knowing that he only has a few months left. And I was very busy, but I could tell he was kind of asking me questions about palliative care, but didn't know the terminology, didn't know anything. And I actually sat there for 10 minutes and just had a conversation. He told me about his daughter. He told me about his father and his mother, and it was one of the better 10 minutes that I spent that whole day, as opposed to yelling at a consultant on the phone or being very frustrated. And I hope that I gave him at least terminology and tools so that when he goes back to his oncologist this week, I hope that I was able to tell him, these are the questions you need to ask. These are the resources you need to learn how to get access to.
Can I make one quick comment just from kind of the more third world perspective? So I know we're running out of time, but I'll be very quick. It's really encouraging to hear, your comments on palliative care is really easy to do in the EC. I totally agree. And we have kind of an opposite situation here. So here, like a 94-year-old demented Alzheimer's patient will never, ever get onto a ventilator in the state system just because we don't have enough ventilators. So we're very strict about kind of resource allocation. The people who have the best chance will get the resources. So we kind of do a lot of palliative care in the EC. But what I found is that often when that decision is made really quickly and really easily. Okay, not for ICU, but then the next step doesn't happen, which is, okay, now what can we do to relieve suffering, talk to the family, what are we going to do for the patient anyway, you know? And it's really something I try and teach my guys, you know, that even though the patient's not a candidate for full intervention, that's not to say we have nothing to do for them, you know. So I really agree with you. I find palliative care one of the more rewarding things that we do, you know, speaking to families and relieving pain and relieving kind of anxiety. It's really easy things to do. We can all do it in the EC. We have to do it probably a lot more than you guys have to do just because of how we work and where we work. But yeah, this has been a really encouraging kind of conversation.
Jordana, did you want to make any comments about the clinical aspect of this incorporation of palliative care in the emergency department?
Yeah. So even while reading this book, I work also in Brooklyn, New York, and we have a large elderly population where we work. And so these issues come up all the time, and it is, I think, especially for the residents, there tends to be, it contradicts why they went into emergency medicine or what kind of care they think they need to give, which is being very aggressive. And, you know, we do have these conversations of what the patient needs, what the family needs, and I think when we talk about legality, just documenting clearly, like a reasonable person, what this family wants, what this patient wants, the conversations you had, what your goals are for this care. You know, it's totally reasonable to offer better care for our patients and not be aggressive in certain situations and do the right thing. It really comes down to doing the right thing for your patients and their families.
So we had one question from the Twitter feed that came up, and it was about the comments that we made about millennial learners. So I believe that was Bonnie. Do you mind, and everyone can please comment, just clarify what is so challenging about the millennial learners that maybe this book wouldn't be so appropriate for them? I have my own thoughts on them, and I think...
Why don't you bail me out then? I find that millennial learners they want the answer as a multiple choice. They don't want to, and these are just generalizations, and please, I'm not an expert on it, but this is, you know, I find that they also, it has to be right or wrong. There's absolutely no gray with that generation. Now, that's not true for each individual of that generation, but that's my issue with them. And I don't think that, I think that this book, because they're really smart, would either be too simple or too complicated for many of the millennials. But I could use some help on this, you guys, please.
I think the problem with millennial learners is just an issue of time, and they're divided. These are people who grew up going to piano class and soccer class, and their entire day was segmented by lessons or completely scheduled for them. And so to take the luxury of setting aside a few hours every week to read a book that is maybe not part of your core curriculum, or a book that you just may have interest in, I think is just so completely out of their realm of possibility. And so when they do get a book that they have to read, the first question will always be, why do I have to read this? What am I getting out of it? And I think that not every book or article you read has to have necessarily 100% application. And I think Nuland even referenced this. Part of being a well-educated person is developing a good generalist background. You don't get a generalist background by reading everything pertaining to your subject. So just like a good ER doctor can do critical cardiac care, critical neurology care, a good person has a wealth of general knowledge behind them by which they can draw from.
Mm-hmm. As a mother of oh, sorry, go ahead. Nothing. Okay. As a mom of 2 little babies, I'm gonna make sure that I make reading time an absolute, because my goodness, I wouldn't think of that as as a problem. But you're right. You're absolutely right. You shuttle kids everywhere, and it makes them not. I don't know if that's great for them, and for learning, and for if they're going to be doctors. So that's good to know. Thank you.
But I think this concludes our discussion, and thank you all so much for taking the time to come. You know, it's not so easy to have free time. And if anybody wants to make one last comment, just raise your hand. Otherwise, the next book that we're doing in July will be spearheaded by Teresa Chan, and it's David and Goliath by Malcolm Gladwell. And we'll announce the dates and let everybody know. And for anyone watching, if you have any interest in being a part of the book club, we would love to have you. If you have any recommendations for books to read, we would love to hear them as well. Thank you again so much.
Bye.
Nice meeting everyone.
Thank
Thanks,
you.
everybody.
Bye.